Hello everyone, I'm Dr. Sandeep Sharma and I've come here with the much promised part 8 video of focused rapid revision in medicine relevant for FMG exam, and here we are going to take up thyroid disorders, lots of one-liners, and focus will remain on diabetes mellitus, and some miscellaneous topics also will be covering. Again, the rules will remain the same. I will not go into unnecessary concepts unless they are relevant for the exam. We have to cover maximum ground. Again, this is only a revision video, so use it with your notes. By itself, it will not be, sufficient for you to crack the entire question, but it will give you a fighting chance if you feel that you have been lacking. And if you have already read your existing medicine notes and you feel they are not adequate or you are not getting that confidence, this video and this discussion is going to be that confidence booster. I will be telling you what questions are being asked and how you are going to apply those concepts in your questions. So let us start with the discussion. This is my Telegram discussion group. I shared the link in the previous video also. So all the PDFs and everything I will be sharing in this group, right? So you can join it there and all the PDFs will be there. And let us go scenario wise. So scenario number one, examiner will say that there is a middle-aged female who is hyperactive. So something which is more common in a middle-aged female. She is found to be hyperactive. She has tachycardia even at rest and she has palpitation. There is weight loss happening in the lady and she cannot tolerate heat. There is non-inflamed orange-red plaques which are present on the anterolateral aspect of the tibia. We call it as pretibial myxedema. So non-inflamed orange-red plaques on the shin bones, generally bilateral, can be unilateral also. We call it as pretibial myxedema. And when you look at her, she has a staring appearance. There is lid retraction and the eyes appear to be very prominent. I hope that by this time you already know the diagnosis. These are the key words. But not just this. Examiner will say when you do thyroid scan, you find diffuse increased uptake. If you practice previous year question, diffuse increased uptake is seen in which condition is a standard standalone one-liner MCQ also. It is not there in the medicine part. It is given in the surgery and radiology part of your discussions, of your PYQ recalls. So if you have a picture like this, where there is hypertension, there is tachycardia, there is weight loss, there is a staring look, and there is pretibial myxedema, the patient is likely to have primary hyperthyroidism, also called as thyrotoxicosis, and the most common cause of primary hyperthyroidism, particularly in ladies, it is Graves' disease, right? So how would Graves' disease pretibial myxedema look like? This is a photograph. Again, it is a image-based question which has been asked in the NEET PG exam. So they will show this image. They will say lady has a staring appearance and she has tachycardia and legs are showing the following. What is the lesion likely to be there? This is how pretibial myxedema looks like. Here it is bilateral, here it is bilaterally symmetrical. Sometimes it can be unilateral as well. So what are the things about Graves' disease that we should know? Examiner generally focuses on the treatment of Graves' disease. So treatment wise, we have three options available. First treatment option is you can go for anti-thyroid drugs. There is thyrotoxicosis happening, so anti-thyroid drugs can be used. Three types of anti-thyroid drugs are available. You have propylthiouracil, you have carbimazole, and you have methimazole. Carbimazole has availability problem in many of the countries, and many of the US and Western countries it is not available. So they don't talk much about carbimazole, although carbimazole is also equally tolerated as methimazole. Wherever possible, remember that methimazole is the drug which is favored, which is preferred in non-pregnant ladies, ladies with Graves' disease when you are trying medical therapy. It is also useful in the late pregnancy, where teratogenic effects will be minimized. Carbimazole and methimazole are generally avoided because of their teratogenic action. So which is the drug which is favored in the first trimester? It is propylthiouracil. MCQ one-liner, which is the anti-thyroid drug which is relatively safe. See, no anti-thyroid drug is absolutely safe, but relatively safe in the first trimester of pregnancy is propylthiouracil. So this is the preferred agent in first trimester of pregnancy when the lady has Graves' disease. This is also the preferred agent in thyrotoxic crisis. Sometimes patient presents with thyrotoxic crisis, so there also propylthiouracil is effective. Propylthiouracil also inhibits the peripheral conversion of T4 into T3. Although in Graves' disease itself, according to Harrison, this concept is not very applicable, but in patients with thyrotoxic crisis or severe acute symptom, propylthiouracil has been found to be more effective, and that is why in an acute crisis-like situation, propylthiouracil is used. However, propylthiouracil has a problem. It has a serious side effect of hepatotoxicity. This hepatotoxicity is worsened. It can cause hepatic failure if there is a pre-existing hepatic disease, or if there is a younger child or adolescent, or if there is a female. Adult males generally respond to propylthiouracil better. So important side effect to remember regarding propylthiouracil, this is hepatotoxicity. I'm putting a Q. Why? Because it's a pharma MCQ as well. We are trying to cover as much ground as possible. So propylthiouracil, carbimazole, methimazole, any of them can be used. Second treatment for a patient of Graves' disease is iodine 131 therapy. Iodine 131 therapy. I hope you know that there are 3 types of iodine isomers. Among them, there is always confusion that which one to be used where. Remember that iodine 121, 123, iodine 121, they are useful for diagnostic purposes. Whereas iodine 131 is more, versatile, and this is useful for diagnosis as well as for ablation of the thyroid. So treatment purposes, iodine 131 is the one which is favored. So iodine 131 therapy can be tried. Sometimes people try variations called as Lugol's iodine also. You read about it in surgery. And third is total thyroidectomy. After you do total thyroidectomy, then the patient will need to be put on lifelong thyroxine supplementation. And total thyroidectomy, although surgical textbooks say that this is the treatment of choice, Harrison very clearly says that different centers have different options. If the patient can be well controlled on anti-thyroid drug, the world is moving away from total thyroidectomy. So this is one small variation in the treatment options across medicine and surgery. Surgery people say total thyroidectomy is always the therapy of choice. Yes, it is. But you are permanently removing the gland, and many times this radical procedure is not needed according to Harrison in case the patient can be well controlled with the other medical therapies, right? So again, it's a matter of perception, and unlikely examiner is going to ask you. But if a surgeon is putting an MCQ and he or she feels that I have to put a surgery question, and they put a question like this, which is the overall therapy of choice or the therapy which is curative in a way, the answer will be total thyroidectomy, right? So this is the first scenario and the quick review that we have done. Second is lots of one-liner are asked related to thyroid scan. When you do a thyroid scan, you find various types of patterns. We call them as nodules. So the type of pattern and the nodule gives you an indication for the underlying disease. So because it's a revision session, so I'll not go into how the procedure is performed. What is the interpretation is what we are going to remember. So warm nodule is seen in normal thyroid. So that is a normal thyroid. If the question says, examiner says hot nodule is present, again hot nodule is found to be mostly normal. Mostly normal. In bracket you can write they have a 1% risk of malignancy. So generally again it is found to be normal. They have only a 1% risk of malignancy. Virtually always they are normal. Cold nodule will be increasing the risk of malignancy. So that increases the risk of thyroid cancers. So which thyroid cancer commonly produces cold nodule? Most commonly it is produced by a cancer called as papillary carcinoma of thyroid. Papillary carcinoma of thyroid. Then is diffused increased uptake that will be seen in patients with Graves' disease. If the examiner says mixed hot plus cold nodules, also called as asymmetric pattern or asymmetric uptake of thyroid on thyroid scan, the answer will be toxic multinodular goiter. Toxic multinodular goiter. And finally, diffuse decreased uptake will be suggestive of a disease called as Hashimoto's thyroiditis. Hashimoto's thyroiditis. We are not discussing Hashimoto's thyroiditis separately, but a few points about Hashimoto thyroiditis you can remember. It is a common cause of hypothyroidism in middle-aged females. It is more common in females compared to males. Second, in these patients, goiter is often found to be present. Goiter is often present in these patients. What are the conditions which are associated with Hashimoto's thyroiditis? These patients, more than 70% of these patients are found to be anti-TPO, thyroid peroxidase antibody positive. So it is a kind of autoimmune disorder. So anti-TPO is found to be present. Many patients who are negative for anti-TPO may be having anti-TG. TG stands for anti-thyroglobulin antibody, autoantibody in these patients. These patients are also associated with HLA. What are the HLAs associated with it? The three important HLAs according to Harrison are HLA DR3, DR4 and DR5. Other HLAs may be associated, but HLAs like B5, B8, although they are mentioned in the literature, their association is doubtful and controversial. So controversial cheese examiner will not put, so we are not writing it here. And Hashimoto's thyroiditis patients will require levothyroxine therapy. They will require levothyroxine therapy. Now the question arises that how to start levothyroxine, not only in a Hashimoto thyroiditis patient but other patients as well. And this question has been asked as a tough question in your exam. I will show the question also, how to start levothyroxine. So let us make a simplified chart to remember that. So the age, if the age of the patient is less than 60 years, the starting dose of levothyroxine is 50 to 100 microgram per day. It is not per kg per day, it's not a pediatric case. So 50 to 100 micrograms daily. And after that, you will increase or decrease the dose by 12.5 to 25 microgram. This can be done every 3 to 4 weeks. This can be done every 3 to 4 weeks. Ideally, you should be doing a TSH repeat testing and deciding. Many times you can increase and decrease by simple clinical assessment and improvement in the symptoms also. So TSH measurement ideal but not always needed in age less than 60 years for increasing or decreasing the dose. If the symptoms respond, you may clinically take a call not to do TSH in such patients. If the case says age of the patient is 60 years and above and it is hypothyroid patient, or there is a cardiac patient with hypothyroidism, for example, a post-MI or post-stroke patient, not stroke, post-MI or post-cardiac disease patient with hypothyroidism, the starting dose in these patients will be different. You will be starting with the lowest possible dose, and the lowest possible dose will be 25 micrograms per day. And because any dose modification, increase or decrease in these patients will be done by 12.5 microgram, and it should be guided always by TSH values. So every time you have to increase or decrease the dose or change the dose, TSH value measurement is mandatory in such patients. Right? So you have to cram it up, you have to remember it. Why? Because there are questions have been asked. I will show you a sample question. This is MCQ FMGE exam December 2021. The question is very long. Don't get overwhelmed by such questions if you get them. 65-year-old male. So it is a more than 60-year-old patient. He has weakness, lethargy, cold intolerance and slow ankle jerk. So this is clinical feature of hypothyroidism. On TFT, normal value is 0.4 to 4.0, TSH is 16. So TSH value is increased. T4 value, normal value is 0.6 to 1.6, T4 is decreased. And T3 value, normal is 230 to 619, and here they are saying 70, so T3 is decreased. So this patient is hypothyroid. Obviously, you have to start levothyroxine. And giving liothyronine and levothyroxine, there is no such indication, so D cannot be the answer. Now we know that in a patient who is 60 years and above or a cardiac patient with hypothyroidism, you will start with the lowest possible dose. Lowest possible dose is 25 microgram, and you will increase the dose gradually in these patients. And so the answer is B. Now you may ask me, sir, why not C? Because when you are starting, this is a patient with thyroxine deficiency. Only when you have increased beyond, say you have gone up to 100 or 110 or 100 or 125 or 112.5, thus that kind of dose you are giving, and hyperthyroid features start to appear, then you will consider reducing the dose. If you have started with the minimum possible dose, the only option will be hiking the dose. You understand? So minimum possible dose is 25 microgram and increase the dose gradually because it is a hypothyroid patient. That is your answer. So remember this, what I told you, and let's go to the next scenario. Before scenario, we have some thyroid cancer one-liners to discuss. So these are taken from standard textbooks. Let us do a rapid fire review. What is the sequence of thyroid cancers in decreasing order? The most common thyroid cancer is papillary. Second most common after that is follicular. Third after that is medullary. And fourth after that is anaplastic. And there is a fifth variety also, thyroid lymphomas. You can consider they are almost as prevalent as anaplastic, so they are also rare. Now, Hashimoto thyroiditis increases the risk of which thyroid cancers? Two cancer risks are increased. It increases the risk of papillary carcinoma of thyroid. It also increases the risk of thyroid lymphomas. So thyroid lymphomas virtually always occur in an underlying Hashimoto thyroiditis patient. Which is the most common thyroid cancer in iodine sufficient area? The answer is papillary carcinoma. Which carcinoma has orphan any-eyed nuclei and psammoma bodies? Very, very important. It has been asked multiple times in pathology, in surgery, and also in medicine. The answer is again papillary carcinoma. Whenever you are revising it, make sure that in the last week before the exam, you look at how orphan any-eyed nuclei look like in pathology and what are the causes of psammoma bodies. Again, in pathology, it's a very, very frequently asked question in your FMGE exam. It's pathology, and it will make the video too bloated because we have to spend half an hour on diabetes. So I'm just skipping through, but telling you that when you read pathology, just go through these bodies. Very commonly they are asked in the exams. Then we have iodine deficient area. Which is the most common thyroid cancer in iodine deficient area? The answer will be follicular carcinoma. Which cancer occurs in a long-standing goiter? Again, the answer will be follicular cancer. So Hashimoto thyroiditis will have a goiter, but goiter untreated will develop most common which type of cancer? The answer will be follicular carcinoma. FNAC is the investigation of choice in papillary carcinoma, but FNAC cannot distinguish follicular adenoma versus carcinoma, so FNAC is not useful in follicular cancer. In a follicular cancer, you always need to do, suspected follicular cancer, you always need to do biopsy. So excisional biopsy is always the investigation of choice. Name the cancer, thyroid cancer, where calcitonin is increased but calcium levels are normal. It will be medullary carcinoma of thyroid. Medullary carcinoma, if you remember, this is the one which can be sporadic or it can be genetic. The genetic ones are a part of MEN2 syndrome, multiple endocrine neoplasia. We have read about it. And finally, radioactive iodine is not useful in which thyroid cancer? This is a INICET question. Obviously, they had made a case out of it. The answer is medullary carcinoma of the thyroid. Medullary carcinoma of the thyroid. Additional thing you should remember that papillary carcinoma tends to show lymphatic spread. It tends to show lymphatic spread, lymphatic metastasis most commonly. Whereas follicular carcinoma tends to show hematogenous spread most commonly. Hematogenous spread. So this will be generally spreading to the bones. This lymphatic spread will generally be happening to the local lymph nodes. Although metastasis can commonly occur in papillary carcinoma to lungs as well. So lymph nodes and hematogenous dissemination, of course, to lungs can also happen in papillary carcinoma. So these are some one-liners. I hope most of them you know. If you don't know them, you can add them to your existing notes. Let us look at the next scenario. Scenario number 2. It's an easy one, but question on this has been asked in the exam. Look at the question. They will say there is an adult patient with spade-like very broad hands, very big hands. They will be having a normal height. There will be pronathism. What is pronathism? Forward protrusion of the jaw. And there will be increased heel pad thickness in the feet. When you examine them, when you check their vitals, they will be having tachycardia. They have also increased risk of arthritis and many times some breast development leading to, with a watery or milkish discharge can occur even in males. We call it as galactorrhea. If you have a feature like this, the patient is likely suffering from acromegaly. Remember that this acromegaly, the cause is increased growth hormone secretion. But increased growth hormone secretion, if it occurs before fusion of the growth plate, that causes gigantism. So those will be having a very long height, like you see in the Great Khali. But patients with acromegaly, the growth hormone secretion happens after 16 years of age. And so the height in these patients is found to be normal, but the other organ manifestations will appear. So what is acromegaly? It is a condition characterized by increased growth hormone, that is growth hormone excess beyond 16 years of age. Beyond 16 years of age. What is the most common cause of acromegaly? It is caused by pituitary adenomas. Pituitary adenomas. And this is an old one-liner MCQ also. Now, what are the, remember that apart from these features, these patients are found to have normal height, and they are also found to have normal fertility also. So fertility in these patients is also found to be normal. Now, what are the investigations that you will do? For the purpose of screening, you can go for serum IGF-1 levels. So screening is done by serum insulin-like growth factor 1 levels, which will be increased in a patient with acromegaly. And for the purpose of diagnosis, you will be doing a test called as glucose challenge test. Glucose challenge test for growth hormone levels. So growth hormone levels after a glucose challenge test needs to be done. And once the diagnosis is confirmed, MRI brain is also needed to identify the common cause, that is pituitary adenoma. Now, what is the therapy which is available? Therapy, ideally, you should be planning a neurosurgery. A neurosurgery consultation should be taken and a neurosurgical intervention. If it is a pituitary adenoma, that should be started. Plus, you will be giving, till surgery can be done, you will be giving drugs therapy. Now, two types of drug therapies are available. First is called as growth hormone receptor blocking therapy. So first is growth hormone receptor blockers, and the typical example of that drug is pegvisomant. Pegvisomant. Second type of therapy is depot preparation of lanreotide. Depot preparation of lanreotide. What is lanreotide? It is a type of somatostatin analog. And by this somatostatin analog action, it reduces growth hormone secretion in the patient. And depot preparation makes sure that you don't need to take the drug on a daily or a long-term basis. And this tends to decrease the growth hormone secretion. And in fact, according to most of the standard textbooks, these days, depot lanreotide is considered the medical therapy of choice in these patients. Or if they ask you drug of choice, the answer will be depot lanreotide. This is a scenario-based question asked a couple of years back in the FMGE exam. So what is the medical therapy of choice? Somatostatin analog like lanreotide. Can you use oral octreotide? Yes. And another older alternative is oral octreotide can also be used. But the problem is you need to take it on a regular basis. And so it is not very preferred these days. So this is the therapy. This is how questions are asked. Have a look at the question. January 23 question, preferred management of acromegaly is. Now, this is January 23 question. This is how it is given in your books also. Trust me, this question can be repeated, but in a different way. Examiner will not say acromegaly. If they have to repeat, what they will say is they will make a case. A normal height, 25-year-old person, broad spade-like hand, increased heel pad thickness, normal fertility, normal height, positive, increased IGF-1 levels in the blood. Which among the following drug will be preferred? So this will be acromegaly patient. What is the preferred management? It will be lanreotide depot formulation, which is given in these patients. Okay. So question answer to question number January 23 question is B, lanreotide depot formulation. Let's go and let's look at a revision table related to diabetes insipidus versus SIADH. Sometimes questions. Now have a look at this table. This table is comparing diabetes insipidus versus SIADH. SIADH stands for syndrome of inappropriate antidiuretic hormone. secretion. So diabetes insipidus, SIADH, both of them are related to ADH, that is vasopressin levels. One is due to excess, one is due to deficiency. So first we look at diabetes insipidus. The cause of diabetes insipidus is either deficiency of ADH. If there is complete deficiency of antidiuretic hormone, we call it as central diabetes insipidus. But if it is being produced normally, but there is a deficiency of receptors, it is unable to act on the kidneys, then we call it as nephrogenic or peripheral diabetes insipidus. So there are two types, central and nephrogenic or peripheral. Now, there are a lot of causes related to central, related to nephrogenic. Details you can do if you are from your existing notes. Central diabetes insipidus can be there due to CNS causes. It can occur due to CNS tumors, head trauma, irradiation, various types of causes, hydrocephalus, they all can cause central diabetes insipidus. On the other hand, nephrogenic diabetes insipidus can be a part of certain syndromes. It can be drug induced as well. Now, two PYQs you need to remember that lithium is one of the common drugs which causes nephrogenic diabetes insipidus. But for treatment of nephrogenic diabetes insipidus, you need to give thiazide diuretics. Both of them are one-liner. You can add to the notes. In diabetes insipidus, the urine output is increased, that is polyuria. The function of antidiuretic hormone is preservation of free water. So free water will be lost, leading to polyuria, and even polydipsia will occur in the patient. Hypernatremia will be there in these patients because water is getting selective water loss is happening. So sodium will be concentrated in the blood, leading to hypernatremia. Plasma osmolality directly relates to sodium, so it is increased, and urine is very dilute because free water loss is happening, so urine osmolality is decreased. On the other hand, SIADH, the cause is excess ADH production or action in the patient. And SIADH, you need to remember, I'm a pediatrician, so I will always bring a bit of pediatrics, that 10 to 25% patients of pneumococcal meningitis develop transient SIADH lasting for 4 to 8 weeks. So that also needs to be managed in some patients. So SIADH can also be, excess ADH production can also be a transient phenomena in these patients. Now, urine output in these patients will be normal to decreased. Now, there will be dilutional hyponatremia happening because free water loss cannot happen from the kidneys, so water will dilute the sodium. Plasma osmolality in these patients will be reduced and urine osmolality will be increased, leading to concentrated urine being produced. So this is something that you have already done. So just a quick recap of what you have done in these two topics. Moving further, our focus of attention is diabetes mellitus. The first thing about diabetes mellitus is the simplified etiological classification that we need to remember. So first is type 1 diabetes mellitus, which is the most common variety, also called as insulin dependent diabetes mellitus. This variety of diabetes mellitus is found to be autoimmune in nature. There is formation of anti-islet cell antibody which destroys the beta pancreatic cells, and this is the variety which is associated with HLA-DR3 positivity and HLA-DR4 positivity. So the most common variety generally, it is type 1 diabetes mellitus, both children as well as adults. Second is type 2 diabetes mellitus, whose prevalence is rising, and this is the variety which occurs generally in adults and obese patients. Type 2 is also called as non-insulin dependent diabetes mellitus. Here the insulin levels are not low, here the insulin levels are actually high. These are the patients who are found to have insulin resistance. These are the patients who are found to have insulin resistance. What I am doing is telling the classification, and all key points I am writing on the side so you can remember it easily and revise it easily. These are the patients who are found to be obese. These are the patients who have 0.5% risk of developing amyloidosis in later life. Amyloidosis never occurs in type 1 diabetes. In a INI CET question, they had asked which of the following diabetes is associated with, long-standing diabetes associated with amyloidosis. The answer is type 2 diabetes. Many of these patients are having chromosome 6p abnormalities, but there is no HLA association found. And when the recent studies have shown that patients with type 2 diabetes mellitus are found to have increased levels of adipokine, and they are found to have decreased levels of adiponectin. Adiponectin is the protective It is the protective molecule which prevents against hyperglycemia in you and me. And in these patients, this level, due to a variety of reasons, gets disturbed, leading to the development of insulin resistance. And many type 2 diabetes mellitus patients are also found to have acanthosis nigricans. What is acanthosis nigricans? You know it. There is a black discoloration happening at the back and in the neck region in the patient. Now, the third variety of diabetes mellitus is gestational diabetes, which typically occurs during pregnancy, and then we have specific subtypes. Now, specific subtypes, there is a huge list given in the books. There can be maturity onset diabetes of young, we call it as MODY. There can be drug induced. It can be drug induced, typically produced, for example, it can be produced with corticosteroid use. It can occur due to pancreatic disorders. For example, cystic fibrosis can cause diabetes. Remember that cystic fibrosis in a child does not cause diabetes, only in adult it will cause a diabetes. Then mutations can be there, HNF4 alpha, HNF1 alpha, glucokinase and mitochondrial mutations. They all have been associated with producing diabetes. Remember that HNF1 alpha mutation has now been shown to produce a type of MODY called as MODY3. There are multiple types of MODYs which are seen, maturity onset diabetes of the young, and MODY3 is found to be the most common variety. So if someone asks you what is the most common type of maturity onset diabetes of young, answer will be MODY3. Which is the mutation present? It is HNF1 alpha gene mutation which is found in these patients. And you also need to remember that all MODYs, most of them MODYs, they are autosomal dominant in nature. They show mostly autosomal dominant inheritance. Then there is a variety called as transient neonatal diabetes, and finally we have infection associated diabetes. Name 3 infections associated with diabetes mellitus. One is congenital rubella syndrome. Second is cytomegalovirus, and third is Coxsackie virus. Among them, congenital rubella has been found to be having the strongest evidence among the 3 for association with diabetes, right? So if you look at the page, I have not only given you classification, I have also told you one-liners and potential MCQs that you need to remember. Now moving further, we have the diagnostic criteria. Here we follow American Diabetic Association 2021 diagnostic criteria. How do you diagnose the patient? The diagnosis is made according to ADA if there is any sign and symptoms of diabetes, polyuria, polydipsia, weight gain or weight loss, along with random blood glucose 200 milligram per deciliter or more, that is diagnostic of diabetes mellitus, right? This is what they say. In addition, they also give you cutoffs, and they say diabetes is not a single thing. It's always a spectrum. There are normal people, there are pre-diabetic people, and then there are diabetic people. Unfortunately, it's not a thing to say, but many of the pre-diabetic people, they don't even know they are pre-diabetic, right? So many years back, I just got a random testing of myself done, and my fasting sample showed that I was pre-diabetic, right? My fasting plasma glucose was 101. So technically I am pre-diabetic. I got it tested 6 months later. Now my blood glucose was 98. So now I was normal. Then I got it repeated again. Now again my pre-diabetes glucose came out to be 104. So basically, pre-diabetes is one stage where you have a tendency to develop diabetes. My family has a strong history of type 2 diabetes as well as cardiovascular illness. So what it means is diabetes is a spectrum, and type 2 diabetes particularly will not happen overnight. There will always be a progression happening. Having a good lifestyle, having a relatively stress-free life. Now stress-free is something I can't do much about, but having a good lifestyle, healthy lifestyle, avoiding these fast foods and a bit of workload, a bit of physical training, they will always go a long way in ensuring that even if you are in pre-diabetic stage, you don't go to diabetes. At the same time, once diabetes has set in, if it is type 1, you need to give insulin. If it is type 2, you need to give oral hypoglycemic drugs, right? So it is very important that you understand the spectrum. In the spectrum, if you are on the left side of the spectrum, if you are on normal or pre-diabetic stage, great. Having a good lifestyle will ensure that you don't go to the other side regarding type 2 diabetes. Regarding type 1, the unfortunate thing is eventually insulin is going to go away and you cannot stop the progression from diabetes to happen. In type 2, which is the adult form, you still have time. So understanding the spectrum of diabetes is important. There are 3 investigations which are done. First of all, we look at the fasting plasma glucose. The patient should be fasting for minimum 8 hours. Okay. If the fasting plasma glucose is less than 100 milligram per deciliter, normal. If it is 100 to 125, pre-diabetes. If it is equal to more than 126, that will be suggestive of diabetes in the child. These are the cutoffs. You have to remember them. Like you're sleeping and somebody wakes you up, still you should know. Without asking why did you wake me up, you should know. And someone asks you what is the cutoff, you should know the cutoff. Second is the HbA1c value. Normally it is less than 5.6%. HbA1c tells you the long-term diabetic control. It tells you the sugar control, how much of binge eating of sweet things you have done in the last 2 to 3 months. Okay, so 8 to 12 weeks period, it tells you about the glucose control. So normally less than 5.6, pre-diabetes is 5.6 to 6.4 and equal to or more than 6.5% is HbA1c. There was a person who came to me. He has a child who has type 1 diabetes. The father is also diabetic. So the father shows to another person, to a eminent endocrinologist in Chandigarh. And I'm not an endocrinologist, by the way. I'm a general pediatrician, but the kid is brought to me. So I looked at the reports of the kid. The kid had a very good glycemic control, and the kid is on insulin detamir right now with regular insulin also. I asked the father that how are you doing? So he said, I am doing fine, just that my blood test is not good. So I asked him to show his blood test. I looked at his blood test and his HbA1c was 10.6%. And I was like, sir, what are you doing? 10.6%. Don't you want to see your kid grow, and why do you want to burden your kid with getting renal transplant done? He said, you know that renal transplant will be needed eventually. CKD will develop if you are carrying so much of blood glucose and not doing anything about it. So he was dismissive. He said, no, I've started with naturotherapy, Ayurveda and other things. I counseled him that yes, you can continue with all these things, but if you are insulin deficient, you have to take insulin, right? There is no other way. So you have to take insulin, and I advised him. And then he said there was Deepavali, and during Deepavali I had taken a lot of rasagullas and sweets. But I was making sure that my tea does not have sugar. I said life doesn't work like that. You're taking tea which does not have sugar, and then you're taking 2 rasagullas. Now you are a diabetic person. Your HbA1c 10.6%, right? So life doesn't happen like that. And being doctors, we also need to understand and emphasize that in counseling. And then we have the 2-hour plasma glucose test, which is also called as the glucose challenge test or glucose loading test. Here we give glucose loading, and then 2 hours later we check for the glucose. This is the FMGE MCQ recently asked in last year 2024. How much glucose is used while doing glucose loading test? It is 75 gram glucose which is used. If normally 2 hours later if you check, it is less than 140, that is normal. 140 to 199 is pre-diabetes, and equal to or more than 200 is diabetes in the patient. So this is a very, very important table. How MCQs are asked? 2 MCQs I want to show you. Now have a look at these 2 past MCQs. They look similar, but people make a mistake in answering them. The first question says, version 1, what is the HbA1c cutoff to diagnose diabetes according to the guideline? And if you know the guidelines correctly, you would know the answer to this is 6.5% is the cutoff. Okay. Second question looks something like this. This question was asked in FMGE January 24 last year. 50-year-old diabetes mellitus patient comes to you. He has symptoms of diabetes. What shall be the target HbA1c for determining optimum diabetic control? The first question is telling you the diagnosis. Diabetic control is not 6.5%. The diabetic control in this patient will be a table that I want to show you. And then after solving that table, I will come back to this question again. So have a look. So what are the treatment goals in diabetes? Treatment goals and cutoff are different from the diagnostic cutoff. So there is a table given in Harrison, this table. Tomorrow when you prepare for NEET PG INI-CT, you have to cram this table. But I do understand that FMG exam is just around the corner. If you can't remember, ideally you should, but if you can't remember the entire table, just look at this particular part. What are the HbA1c cutoff on follow-up that we need to see if a diabetic patient has having proper control or not. When you give insulin or when you give oral hypoglycemic drugs, depending upon the type of diabetes, what should be the target HbA1c? Cutoff was 6.5%, right, for diagnosis. For treatment purpose, for a non-pregnant normal adult diabetic patient, the cutoff is less than 7%. And for an older person or a person with cardiovascular disease, high-risk patient, the cutoff will be less than 8%. So how does the question look like now? This was the question I just showed you. FMG MCQ January 24, 50-year-old diabetic patient, he has symptoms of diabetes. What should be the target HbA1c for optimum control? And here the answer will not be 6.5%. Here it will be less than 7%, and that is your answer. So be careful what examiner is asking. This has been a recently asked question. Variation of this question can be repeated. Now, whenever there will be type 1 diabetes, you need to give insulin therapy. So insulin therapy generally needed in type 1 diabetes. What are the types of insulin? There are 3 types of insulin we need to know: rapid acting, intermediate acting, long acting. It's a pharma medicine overlap question. What are the rapid acting insulins? There are 3 rapid acting insulins approved for use. GAL is the name. GAL stands for glulicine. A stands for insulin aspart, and L stands for insulin lispro. Why do we call them as rapid acting? Because in all these rapid acting insulins, the onset of action is within 10 to 15 minutes. The peak action, the peak of effect is seen around 1 to 2 hours, and the total duration of action in these patients is 3 to 6 hours. So this is the period you need to remember in all rapid acting insulins. Second is intermediate acting insulin, which is also called as NPH insulin. NPH insulin, the onset of action will be in 1 to 2 hours. The peak action will be seen at 5 to 6 hours, and duration of action will be about 12 to 16 hours. Some books say 12 to 14 hours, that is also correct. You have to remember these values, by the way. And then we have long-acting insulin. 3 are long-acting insulin. We have GDD is the name for that. So GDD stands for insulin glargine, insulin datamir. When I was doing my MD, my thesis was on insulin datamir. So insulin datamir, I have given a lot of datamir drugs, and it's a very, very good drug. Costly, of course. And the third one is insulin degludec. Remember that degludec is considered to be the longest acting. Longest acting. When you talk about these long-acting insulin, what are the values you need to remember? First of all, the onset of their action is 1.5 hours, that is 90 minutes minimum. They do not produce a peak. So peak is none. So they are also called as peakless insulins. Remember, long-acting insulins are also called as peakless insulin. Which among the following is a peakless insulin? It's a FMG MCQ. You will find it during PYQ discussion. You might have already done it, seen it. And third is duration of action. Depending upon the type, duration varies between 18 to 24 hours. And this is the table you need to remember regarding long-acting insulin. And if examiner asks you, I'm writing on the side, what is the preferred method, preferred mode of giving insulin? Preferred mode of giving insulin. The preferred mode, ideally, normally we give subcutaneous injections manually, but the preferred mode is these days CSII. CSII stands for continuous subcutaneous insulin infusion. These are automated devices which give insulin as a regular form, and so they are also called as insulin pumps. Their other name, their common name is insulin pumps. But as you can well imagine, they are costly, and availability is a major issue. But if ideally they ask you what is the preferred mode, it will always be CSII administration. So moving further, next is the two important phenomena, Somogyi versus Dawn phenomena. You need to understand that both Somogyi and Dawn phenomena can occur in diabetic patients who are receiving insulin. They are seen in type 1 diabetes patients, and both of them will be having 7 a.m. hyperglycemia. So pre-breakfast hyperglycemia. You need to understand two things here. First of all, what is the meaning of early morning hypoglycemia and what is the meaning of pre-breakfast hyperglycemia? Early morning does not mean morning 7 a.m., right? Early morning means 3 or 4 a.m. So there are a few terminologies we need to know. First of all, this is the table which has been shown. I am adding a one line here and putting it like this. This is 70 milligram per deciliter. This is 70 milligram per deciliter. The first line, which is not touching 70 milligram per deciliter, where blood glucose never goes below 70, is the dawn phenomena. So the blue line is the dawn phenomena. The pink colored line, which is dipping below 70, is the Somogyi effect, right? Also remember, I'm writing at the top. It will make the concept easy. Here I'm going to tell you a concept, of course MCQ related, but it is important that whenever someone says early morning in diabetes, early morning in diabetes means 3 to 4 a.m. the time when many of you are preparing for exams. I hope you are not reading at 3 to 4 a.m. because your body cycle will otherwise go bad. And second is pre-breakfast. Pre-breakfast means timing around 7 a.m. Generally, we assume that 7:30 to 8 a.m. is the time to take breakfast, right? So this is the terminology you need to know. Now, let us go one by one. The first phenomena I want to discuss is Somogyi phenomena. Somogyi, how do you break it down? So much insulin हो गई. So much insulin हो गई कि Somogyi phenomena has happened. It is a stupid way to remember, but you can easily remember. The cause of Somogyi effect is high bedtime insulin. Now somebody gives you, you are a diabetic person and somebody gives you a normal से ज़्यादा dose, high dose of insulin is given at bedtime. So what will happen in these patients is, after you take at bedtime, these patients develop early morning hypoglycemia. Can you see in the photograph? There is a dip happening around 3 a.m., 3 to 4 a.m. So early morning hypoglycemia will occur. Between 3 to 4 a.m. there will be a dip in the blood glucose. This early morning hypoglycemia will lead to increased glucagon release because body has counteractive hormones. So glucagon release will happen. This glucagon release will counteract the effect of insulin which was there, and it will lead to increased rise in the blood glucose. And because it is a diabetic patient, so by the time patient gets up and checks his glucose at 7 a.m., patient will have pre-breakfast hyperglycemia. Pre-breakfast hyperglycemia. So early morning hypoglycemia leading to increased glucagon release, leading to pre-breakfast hypoglycemia is called as Somogyi effect. Whenever they show you a photograph or a graph, the image will be showing a very sharp cut. It will be dipping and then it will be rising again. And the dip will be below 70 milligram per deciliter in the patient. The second effect, the second phenomena is called as dawn phenomena. The second phenomena is dawn phenomena. Remember, dawn phenomena is more common and it can occur even in normal individuals also. It can occur physiologically also. Dawn phenomena mein kya hai? Now, what will happen is during night, sometimes during night, during sleep, there will be a slight dip. There will be a slight dip in the blood glucose level. But this slight dip will not be sufficient to produce hypoglycemia. See, there is no hypoglycemia happening. Look at the graph also as I am explaining. So no hypoglycemia, but slight dip in blood glucose. This slight dip in blood glucose will lead to increased release of cortisol as well as growth hormone levels. And sometimes it will lead to release of some amount of glucagon also. So mild glucagon. See, significant increased glucagon is a feature of Somogyi effect, but mild glucagon release will also be there. What these hormones will do is they will make the insulin receptors. They will make the insulin receptors refractory transiently between 3 to 7 a.m. And so the patient will develop pre-breakfast hyperglycemia. Pre-breakfast hyperglycemia. And in these patients, because the insulin receptors have become refractory, the pre-breakfast hyperglycemia will be greater compared to Somogyi effect pre-breakfast hyperglycemia. So I know it is very tough and it is something that you learn in a regular video, preferably in a face-to-face class. But if it is not possible, and we have limited time available, there are few things to understand. Which is more common? Dawn phenomena is more common. Somogyi effect occurs in high bedtime insulin. There is hypoglycemia, glucagon increases, and there is hyperglycemia by 7 a.m. That is Somogyi effect. What is dawn effect? During sleep, in a normal person, normal diabetic person also, there may be a slight dip. Due to slight dip, cortisol growth hormone increased. They will cause insulin receptors for 4 to 5 hours to become refractory, and that will cause high glucose in the morning. Both Somogyi and dawn are having hyperglycemia in the morning. The difference is Somogyi is due to our wrong dose. Dawn can occur in normal diabetics also. Point to note, there are variations to this rule. It is not as easy, but I am telling in a simplified form, not going into the technicalities and the exceptions and variations. Somogyi effect, hypoglycemia occurs. Dawn effect, hypoglycemia does not occur. So, Somogyi effect and dawn effect both will have 7 a.m. hyperglycemia. The degree of hyperglycemia will be greater for dawn effect in general. That is the all thing. You need to listen to this part of video at least 2-3 times. Once it clicks, it clicks. Still you have doubt, you can always ask me on social media separately. Let's go further. And next we talk about the complication called as diabetic ketoacidosis. Diabetic ketoacidosis is a life-threatening complication mostly seen in patients with type 1 diabetes mellitus. When would you suspect diabetic ketoacidosis has happened? The patient with type 1 diabetes mellitus presents to you with nausea, vomiting, abdominal pain. There is Kussmaul's breathing, that is acidotic breathing happening in the patient, and they are having fruity odor. They are having fruity odor in urine or breath. When a patient presents with features like this, along with, of course, there will be polyuria, polydipsia also, you will think the patient is having diabetic ketoacidosis. So, emergency patient, Kussmaul's breathing indicates acidotic breathing, fruity odor indicates ketosis in the patient. So, these patients will be presenting like this. How to diagnose a diabetic patient? As soon as patient comes, after airway, breathing, circulation, ABC, emergency thing, you take the blood glucose and check. You take out a blood sample and check. What are the key diagnostic features? First of all, there will be blood glucose equal to more than 200. Second, high anion gap metabolic acidosis. How do you say? The serum bicarbonate, when you do blood testing, it will be 15 to 18 milliequivalents per liter. So serum bicarbonate will be low and the venous pH of the blood will be low. And third, there will be ketosis, that is ketonemia, either ketone bodies in the blood or ketone bodies in the urine. So all three should be present. If all three are present, we say the patient is having diabetic ketoacidosis. Okay. Now, what is the most common ketone body? It is beta hydroxybutyrate. Second common is acetoacetate. Third common is acetone. Acetone is the one which is responsible for fruity odor, whereas beta hydroxybutyrate is the one which is serious as well as sensitive for diagnosis. This is more sensitive for diagnosis. Now let us understand, why does diabetic ketoacidosis happen. Don't worry, I'm not going to write the complete pathophysiology here, but it is relevant for your exams and you need to know why it happens, so it makes you easy for you to understand. So for example, just imagine that there is a type 1 diabetes mellitus patient. So type 1 diabetes mellitus patient, he will already be on insulin. This patient, due to some reason, either skips insulin dose, or this person develops some acute stress, or this person develops some acute inflammation. Acute stress does not mean only the mental stress we are talking about. Any kind of surgery, trauma, physical trauma, that will also be a stressful condition. So whenever there is skipping of insulin dose, acute stress and acute inflammation, there will be a hormonal imbalance produced in the body. There will be a sudden dip in the circulating insulin levels. Plus, there will be a sudden increase in the glucagon levels. And if it is inflammation, then the other inflammatory hormones which are involved in maintaining blood glucose, they will also be rising. So the net effect of this will be this increased insulin will cause hyperglycemia. So blood glucose more than 200 will occur. This hyperglycemia will precipitate osmotic diuresis in the kidneys. And due to osmotic diuresis, there will be polyuria, polydipsia, etc. And osmotic diuresis will lead to development of dehydration. Plus, sudden fall in insulin and sudden increase in glucagon will cause increased lipolysis in the body. This increased lipolysis by a cascade of reaction will result in acidosis, and this will also lead to increased ketone body formation. And this ketone body formation will lead to ketonemia or ketonuria in the patient. So as you can see, this is what comprises diabetic ketoacidosis. Please understand that this is a very simplistic way of showing it, but this, if you understand it well, if examiner is asking you a tricky question, if examiner is hell-bent upon checking whether you know diabetes properly or not, this much of information should be good enough at your FMG level and even at your NEET PG level to understand what is happening. So diabetic ketoacidosis patient will have hyperglycemia, there will be metabolic acidosis, there will be ketosis, and the patient will be dehydrated. And this is how the patient will manifest. Now, how you are going to manage the patient? Management of DK, I'll not go into details. I'll stick to what examiner asks. So DK patient comes to you, airway, breathing, circulation, just like any emergency. After that, the first thing that proper management that you do is fluid resuscitation. Fluid resuscitation because 100% of diabetic ketoacidosis patients are having dehydration. Even if the signs of dehydration are absent, you will assume the cellular dehydration is present in the patient, even if the signs of dehydration may not be there. So we will start with the fluid therapy. Now, what fluid therapy we will be using? We will always be preferring normal saline in the patient. You will give 2 to 3 liters IV normal saline over 1 to 3 hours and then shift to half normal saline infusion because you don't want any hypernatremia to happen suddenly in the patient. And after fluid resuscitation, you will be starting with insulin. So don't give insulin without fluid resuscitation. What is the first step in management of DK? Answer is fluids. After fluid, what is the second step? You will check for insulin. Now, there is another catch here. Insulin will always be needed in diabetic ketoacidosis, but it is not given as the initial therapy. There is a problem. Many patients who are presenting with diabetic ketoacidosis, it is found that they are already having low body potassium. And when you start insulin, you know from pharmacology and other aspects of medicine that when you give insulin, insulin causes the inside movement of potassium into the cell. So if there is already hypokalemia, that can get worsened and patient can develop arrhythmia. So it is very important that get a serum potassium level done. If serum potassium immediately is not possible, get a ECG done, and in the ECG, watch out for any ECG changes of hypokalemia. If there are no ECG changes, or if the serum potassium immediately the report is available, you check the report and start with insulin. Otherwise, first do potassium correction, add KCl, and then start with insulin infusion. And what type of insulin is used? We will always be using regular insulin in the patient. This also is a past FMG MCQ. Which type of insulin is used in the management of diabetic ketoacidosis? The answer is regular insulin, the normal insulin, not the short acting, long acting. Those forms are not used. Now, in case of adults, you will be giving a 0.1 unit per kg IV bolus according to Harrison, and then you will shift to 0.1 unit per kg per hour infusion IV. Based upon the response, you can increase the dose, you can maintain the dose, and if the patient starts improving, slowly you can taper and bring to subcutaneous insulin. There is a catch. This is for adult patient. If the patient of diabetic ketoacidosis is less than 18 years of age, because we know that type 1 diabetes can occur in children, and children can also present with diabetic ketoacidosis. Never give bolus of insulin, directly start infusion. Why am I writing this? There is a question on this in INI-CET 2023. I know you are not sitting for INI-CET, but it is something which examiner has already asked. Remember the funda. Adult, you give 1 bolus of insulin followed by insulin infusion according to Harrison. There are many guidelines which say directly start insulin infusion also. We will stick to what Harrison says. Harrison textbook of internal medicine is the final authority here. Child with DKA, you will never give bolus. It has been shown to worsen the patient. Always start with the IV infusion directly. Dose will remain the same. And thirdly, you will give supportive therapy. Supportive therapy will be in the form of antibiotics if there is infection. Any other electrolyte imbalance happens, you will manage that, and so on. And FMG MCQ, what is the cause of death in diabetic ketoacidosis? It's a past MCQ again. The cause of death in these patients is cerebral edema. So these patients die due to cerebral edema. Now, there is another thing. Diabetic ketoacidosis is the life-threatening complication seen in type 1 diabetes. Do you know that type 2 diabetes can also have a life-threatening complication? The name of that complication is HHS, also called as HHC. What is the meaning of HHS? HHS stands for hyperglycemic hyperosmolar state. If sometimes it is written as hyperglycemic hyperosmolar coma. So how do you distinguish DKA from HHS? So what is the full form of HHS? Hyperglycemic hyperosmolar state. It's an acute life-threatening emergency seen in patients generally with type 2 diabetes. Now, HHS less frequently asked in the exam, but examiner may ask you to differentiate DKA from HHS, or they may ask you question like all of the following are seen in DKA except, all of the following are seen in HHS except. So both of them are emergencies. DKA is occurring in type 1 diabetes, HHS is seen in type 2 diabetes. Second point, DKA patient can have altered sensorium, but he will never come unconscious or comatose, whereas HHS patient often presents with coma. So altered sensorium can be present in both, but comatose unconscious patient is generally seen in HHS. Third thing, fruity odor which occurs due to ketosis and Kussmaul's breathing which occurs due to acidosis, they are never seen in HHS. And obviously when you do the blood testing, blood pH will be more than 7.4 and bicarbonate will be 24 or more in HHS patient. Blood glucose is 600 or more. See, for diabetic ketoacidosis, the blood glucose level is more than 200. But in hyperglycemic hyperosmolar state, the blood glucose more than 600 is seen. There are some people who report, some of my friends who are endocrinologists, they say, we have seen 750 and 800 glucose also, although it is very transient. And so such high glucose is going to cause massive diuresis, massive loss of fluid from the body, and they present with very severe life-threatening dehydration. Many of them can develop shock also. So dehydration is very severe compared to DKA. DKA patients are dehydrated, but these patients are more dehydrated, and so the fluid requirement is even more in HHS compared to diabetic ketoacidosis. Do you need to do the fine details? The answer is no, you need not do that. Now, moving over to there are a few one-liners on diabetes mellitus complication that we need to know. I will not go into details, only the relevant points I am discussing here because we have a limited time in the revision session. So first of all, we have diabetic nephropathy. Long-standing diabetes can damage the kidneys. The disease so arising is called as diabetic nephropathy. Which type of diabetes does it occur? Diabetic nephropathy can be seen in 20 to 40% patients of both type 1 and type 2 diabetes, and if untreated, it can lead to CKD. CKD is chronic kidney disease, that is chronic renal failure. What is the screening test for diabetic nephropathy? There is a test that we can do called as UAC ratio. What is UAC ratio? Urine albumin by creatinine ratio. If it is more than 30, that indicates renal involvement, and generally more than 300 is associated with rapid progression to kidney failure in the patient, right? So screening test name is important, UAC ratio, urine albumin by creatinine ratio. Then when to screen? Now when to screen depends upon the type of diabetes. In a type 1 diabetes mellitus patient, according to American Diabetic Association guidelines, the screening for nephropathy should be started. So start screening for nephropathy at least 5 years after diagnosis has been made of type 1 diabetes. Whereas type 2 diabetes is considered to be a silent killer, and many times by the time it comes to attention, already renal manifestations have started to appear. And so in these patients, you will start screening as soon as diagnosis is made. It is very, very important, and it is something that is frequently asked in your NEET PG and INI-CET exams. It has not been asked so far in FMG exam, but just a matter of time. We know that every year examiner is raising the standard. If it's an easy exam, great, we will score 200. But if it is a tougher paper, we should still be able to solve some tough questions in expected topic. And diabetes is an expected topic, so it does no harm to remember this important funda. This funda will stay with you till you keep giving competitive exams, right? Now, what is diabetic kidney disease? There is a definition for diabetic kidney disease also. It is very prominently mentioned in Harrison, but it is missing from many of the resource materials that you might have read. So whenever a patient with diabetes is having increased urinary albumin secretion, or increased UAC ratio more than 30, plus either of the two, along with fall in GFR, estimated GFR, if there is a falling in a diabetes mellitus patient, that is said to be having diabetic kidney disease. So GFR fall is an essential component to call it as diabetic kidney disease. Remember that diabetic nephropathy and diabetic kidney disease DKD are not same. They look same, but they are not same. There is a proper definition to this. This definition has many subtypes also and many components which you can go into details. I would advise once you crack your exam and you are doing internship and you are posted in internal medicine rounds, that is the time you should be reading about it, right? Not now. Moving further, we have renal biopsy which is done, and if you do renal biopsy, it will show a pattern called as diffuse glomerulosclerosis. This is again a past pathology medicine overlap topic. Second is diabetic retinopathy. Now, if there is involvement of retina, the blood vessels in retina, that is diabetic retinopathy. Diabetic retinopathy is found to be more common in type 2 diabetes compared to type 1 diabetes. What is the time to screen by fundus examination? It is the same as above. So type 1 diabetes 5 years after diagnosis, type 2 diabetes as soon as diagnosis is made. What is the earliest finding on fundus examination? Microaneurysms, that is small aneurysm formation in the inner nuclear layer of retina. Then it is of two types, non-proliferative and proliferative. Non-proliferative type shows macular edema, whereas proliferative type shows abnormal vascularization called as neovascularization. And neovascularization can progress to retinal detachment, and if untreated, it can lead to blindness. So whenever there is proliferative type of diabetic retinopathy, these patients require treatment using pan-retinal photocoagulation, or laser therapy can be done. Which type of laser is used in diabetic retinopathy? That is a type of laser called as ND-YAG laser, which is used in such patients. And what is the alternative? Any other drug which can be used? There is a drug called as bevacizumab. If you have remembered monoclonal antibodies, bevacizumab is anti-VEGF, anti-vascular endothelial growth factor monoclonal antibody. It decreases neovascularization in the patient, and it is given by injections into the vitreous humor in the patient. So intravitreal injections can be tried of bevacizumab, but the frontline therapy is laser. This is one condition where early diagnosis and prevention by maintaining good blood glucose levels is better compared to treatment which is done later. And then we have the third complication, that is skin manifestation. So only one-liners we will be writing. Which is the most common skin manifestation in diabetes? According to Harrison, it is xerosis, that is dryness of the skin, followed by pruritus. Harrison says at another chapter, not in the main diabetes chapter, another place in volume 1, it says that xerosis and pruritus is present in virtually all patients of diabetes. So they are the most common skin manifestation. However, the serious skin manifestation which brings the patient to medical attention is non-healing ulcers, non-healing skin ulcers, typically occurring on the foot. So remember, foot ulcers are the serious manifestation which brings to medical attention, but they are not the most common manifestation. There is a difference between the two. Diabetic patients can also develop neuropathy, which type of neuropathic pattern is seen. These patients tend to develop a pattern called as DSPN. What is the meaning of DSPN? Distal symmetric. So distal nerves are involved. They are both sides of the body are involved and multiple nerves are involved. We call it as distal symmetric polyneuropathy in the patient. So these are the additional points that you need to know. And I'm not discussing here because it's a revision video and just a few days are left. But my sincere advice to you, please read oral hypoglycemic drugs. Once you finish this chapter, once you finish this video, before you sleep off or you get up in the morning, first thing you do, oral hypoglycemic drugs. Don't go into unnecessary details. Oral hypoglycemic drugs are useful in type 2 diabetes, divided into two subtypes. Those which increase insulin secretion, those which do not increase insulin secretion. And then there are subcategories in each. Just remember the name of the drug, what class it belongs to, what is the mechanism, which drug is associated with metabolic acidosis, which drug is effective in both type 1 and type 2. Remember, the drug which is increasing insulin secretion will be effective in both type 1 and type 2, right? The one which is acting only by reducing insulin resistance will not be effective in type 1, but type 2 patient alone they will be effective. And then you have to remember one-liners, which drug causes this side effect, which drug causes that side effect. It is going to take time. It is going to take, maybe if you have never read, it will take 1 hour. If you have read before, it will take 30 minutes. Give 2 readings. But question doesn't get asked, it's okay. Not everything will give you MCQ, but oral hypoglycemic drugs always relevant in pharmacology for your exam. You get a question, great, it's a big bonus for you, and it makes sense to revise with the discussion only. And MCQ FMG 2018. In a newly diagnosed case of sick child with type 1 diabetes mellitus, insulin was given. Which of the following will increase? Sick child with type 1 diabetes, you give insulin. What will happen? Try to understand. Sick child with type 1 diabetes, the common complication the child will present with is diabetic ketoacidosis. So when you give insulin, what will happen? In diabetic ketoacidosis, there is acidosis. So there is low pH in the body. When you give insulin, low pH will correct itself. And so which of the following will increase? pH will increase. Remember that low insulin, as seen in diabetes mellitus patients, causes acidosis. Acidosis means pH of the blood is less than 7.30. When you treat the patient, insulin increases, insulin is given. It causes pH of the blood to rise and acidosis resolves. Right? I'm writing like this because I discussed this question in one of my revision classes recently in Delhi, and there also people were saying ki sir samajh nahi aaya, dobara batao. So this is the explanation, I'm writing it here. So this is a FMG 2018 question, right? It was a tough question. Apply logic, you will always reach the correct answer. I will not take much time. I will just say, have you finished endocrinology? Have you finished all the 8 rapid revision videos that I have done? Have you understood them? Great. Now it is time for you to revise and have faith in yourself. End of the day, it's just an exam. Don't take undue stress upon yourself. Exams come every 6 months. You, the person, is more important. And at the same time, you, the person, have to take control of your life and have confidence in your own ability. Aapne padha hai. When you sit in the exam, the answer will be among the options given to you. You will do well. I'm quite sure. If not today, maybe sometime later. But have confidence in your abilities. Go with a smile into the exam. Trust God and trust yourself. All the very best.